A big thank you to the scientific committee members of WoCoVA for this excellent program. And with this saying, I want to hand it over to Josie Stone. She is my co-host. She is at home in Salt Lake City. So, the borders are gone. So let's switch to Josie. Thank you, Josie. Nice to see you here.
Thank you, and good morning, good afternoon, and good evening to all of our listeners around the world. Thank you so much for joining us today. We will start right away with our speakers, and the first speaker I'd like to introduce is Dr. Hudson Garrett. Dr. Hudson Garrett is the president and CEO of Community Health Associations, LLC, and has a faculty appointment as an adjunct assistant professor of medicine in the Division of Infectious Diseases at the University of Louisville School of Medicine. He also co-founded the nonprofit Infection Prevention Institute to help shepherd dissemination of best practices of infection prevention and control across the healthcare continuum of care globally. He holds a graduate certificate in infection prevention and infection control. He has completed the Johns Hopkins Fellows Program in Hospital Epidemiology and Infection Control. He is also a fellow in the Academy of the National Associations of Directors of Nursing Administration, the American Academy of Project Management, and a senior fellow of the Management and Strategy Institute. He was recently inducted this year as a distinguished fellow and practitioner in the National Academies of Practices. He holds graduate certificates in healthcare leadership from both Cornell and the University of Notre Dame. He is also an appointed member of the Advisory Council Committee for the Design Thinking in Healthcare program at Rutgers University. He is a frequent international lecturer in the areas of infectious diseases, healthcare, associated infections, and infection control and prevention. He holds board certificates in patient safety, healthcare quality, vascular access, pre-hospital emergency medical services, flexible endoscope reprocessing, critical care, and infection prevention and control. He is the presidential advisor for the Vascular Access Certification Program. Please welcome Dr. Hudson Garrett.
Welcome to this presentation on COVID-19 infection and vascular access, a pathway forward. Really looking forward as to how do we move and emerge from this pandemic. The objectives of my presentation are to really review the current status and impact of the COVID-19 pandemic globally on our healthcare system, to also look at some evidence-based simplistic ways to practice infection prevention and control, but also be able to deliver upon our promise for safe, effective vascular access for these COVID-19 patients. And then lastly, really define what that new normal may look like for vascular access specialists. I think the biggest question is what is that new normal going to look like? And that's still something that's currently in flux. We're not really finished with defining what that is, but I think there's some good predictions, which we'll go through here in just a second. Basic things like the use of personal protective equipment, ensuring that we have an adequate supply of PPE, making sure that vascular access professionals are armed with the information and training necessary to properly enter the patient's room, how to disinfect equipment like ultrasound. These are all questions that are going to be part of that new normal. I did want to start with a little bit of a background about really where this came from and how it's going to impact us moving forward. Coronavirus has been around for a long period of time, and we've seen them most recently with SARS and MERS. But this particular one that causes COVID-19, which is the infection, is a new novel coronavirus. And so that means that we don't have immunity, we don't have exposure, we don't have vaccines, and we really don't have a proven therapeutic treatment option. And so this particular disease, COVID-19, was broken down based on the coronavirus and the year it was discovered. The presentation clinically in these patients has been a little bit problematic and interesting as it sort of ebbs and flows back and forth. But we've seen that the incubation period is around 4 to 5 days. However, it can go as long as 14 days. And those primary symptoms that we originally led with from WHO and CDC were some of those classic things like fever and shortness of breath and cough. But we've now really realized that there's a lot of asymptomatic carriers and what we also know as super shedders. These asymptomatic carriers are those that are walking around without active signs of infection that may have a high propensity of transmitted infection. So this is why the use of masks and other basic interventions is important. And super shedders are those that have an extremely high viral load and are capable of transmitting lots of viral particles out there into the sort of atmosphere, if you will. And this is where aerosols and things like that come into place. The good news for vascular access professionals is that it's pretty rare that any procedure we'll be involved with will generate an aerosol. However, there may be respiratory care procedures going on in these patients' rooms that we need to be aware of. And that's why that N95 or that respirator protection is hugely important. As I mentioned before, because this is a novel virus, we don't have a vaccine, we don't have a proven therapeutic option, and we really don't have a way to rapidly recognize these new novel viruses until diagnostics are developed. And so the good news is that there's a lot of momentum on all of those fronts. We've got good diagnostics, some of them being more rapid than others. We better understand the transmission of this disease, and we have, updated guidance documents around the world to really be reflective of how this is transmitted. One of the big areas of contention is it respiratory transmitted, meaning is it a typical droplet, or is it aerosolized in the form of like an airborne pathogen, similar to tuberculosis? And what all of the evidence is pointing to is that it is not the same as tuberculosis. So it's not a true airborne disease. But we are continuing to study this very carefully, and we find that most of this stuff is transmitted via droplets. And so the good respiratory protection and good eye protection can help us. But we also want to set up our healthcare environment to ensure that we reduce risk to us as a healthcare team member as well. The impact itself has had tremendous impacts worldwide, way outside of the clinical setting. We've seen PTSD-like illnesses with post-traumatic stress disorder. We've seen certainly the financial hardship with people being furloughed or laid off or losing their jobs. Certainly, there are healthcare workers especially that have chronic health conditions themselves, and this can cause certainly issues from that perspective. And unfortunately, we see a lot of healthcare workers that are unfortunately taking to probably less than ideal behaviors like excess use of tobacco or alcohol or even drugs. And so the impact has long-reaching things that we must think about. It's not something that we're going to see immediately, and it's very different than what we're tracking as far as the COVID-19 disease. We also need to think very carefully about our healthcare worker team. And as we define what that new normal is over the next few months, this is probably what's going to be the most interesting to see how healthcare essentially levels out. What is that new normal? Does that involve wearing a mask all the time? And certainly as vascular access professionals, we're wearing masks when we're doing procedures. So that's something that's not new to us, but the use of a respirator may be. And so, I always say if you've got the right amount of PPE, and that's really the key, it needs to be the right amount of PPE, then we're going to reduce that risk through that control mechanism. Certainly, if we can put a mask on the patient, that's going to help us even more. And then really looking at some of the other elements of transmission like hand hygiene and disinfection of surfaces like our ultrasound machine, and ensuring that we can minimize exposure as much as possible. When you look at, I live here in the United States, and we've had some interesting responses with the federal response from the different federal agencies, and each country has something similar. But what we found pretty universally across the world is a lack of personal protective equipment. We've seen certainly challenges with diagnostic testing to identify the presence of disease. And now with the antigen testing where we can look for the presence of antibodies, this creates a whole nother set of problems. And so what's good is that we're seeing a lot of partnership, we're seeing a lot of data sharing, and it's an opportunity for us to protect the vascular access workforce. From that, however, we recognize that there's going to be specific things that might come up that are new. And this is just one example that happened in New York City with pediatric multisystem inflammatory syndrome. And this is unfortunately not something that is new to us. We have seen this with other novel viruses in the past. In the past, they typically caused pediatric paralysis, typically of the lower legs. And in some cases that came back, in other cases it did not. And so this is not, like I said, something that's totally new to us with some of these rogue viruses out there, but it is definitely something that we have to be aware of, especially for our pediatric populations. The vulnerable populations have evolved over time. We really saw originally globally a lot of people that were impacted were in that 65 years of age or older, and that is now changing in some jurisdictions. where we're seeing people that are younger of age, but primarily a lot of people with chronic health conditions. And unfortunately, what we've seen is probably the most impacted is our long-term care facilities, the skilled nursing facilities that are taking care of these patients. And we recognize that that's coming from the healthcare workers. These residents are not going out of the facility, so that only leaves one route of transmission, and that has to be from the staff. And so anybody that has one of those severe underlying medical conditions, including us as healthcare professionals, we need to be very cautious of this. And really the good news is that we have learned a lot. There's more information that's coming out. I'm so excited to see the vaccine trials that are coming out. We are further studying therapeutic options. There's a lot of international collaboration globally to look at best practices, sharing data, looking at some of what the large pharmaceutical companies are doing, because we recognize that if we inform the public and we activate them as part of that public health effort, that's going to really be one of the best important things that we can do to protect our overall population. And part of that starts with something basic like washing our hands. We certainly know that with these droplets, they can get on hands, they can get on surfaces. And so you can have that gross contamination that's present there, especially if we touch our mucosal membranes like our eyes and our mouth and our nose. And so I always remind people that if you're wearing a mask for purposes of protection of droplets, you really should have on eye protection as well. So these basic mechanisms will really help us. And what about if we get sick? This is probably one of the biggest issues. And so here in the United States, there's been guidance that's issued about critical infrastructure. Healthcare workers certainly fall within that. People that need to be at work because they're critical to survival, if you will. And so healthcare workers, like I said, fall within that characterization. And so if you are exposed, that doesn't mean that you have to go home. It can mean that you can be monitored, self-monitored, public health monitored. There's a lot of different options here. But if you do become sick or if you do have symptoms, it's imperative that you stay home and not report to work. And you also want to isolate yourself from other members of the family. And this has really been probably one of the most challenging circumstances, is that healthcare workers were extremely scared, and for good reason, about infecting their family and loved ones. Or if they did come home, they were quarantining themselves. And so again, there's lots of unintended consequences that go with this type of isolation. And one of the new developments, as I mentioned before, is what type of test should I get and what and when? And so that initial viral test, the one that looks for the presence of the disease in the first place, is a good indicator, a good barometer of sort of what that disease burden is. Whereas that serology test is really looking for previous infection and specifically the presence of antibodies. And I've seen, unfortunately, a lot of people make decisions based on these tests that don't necessarily add up clinically. So, for example, just because someone has antibodies present in their blood does not mean that that person's immune. And so it's important to look at which test is appropriate for the patient, what test might be appropriate for us as the healthcare team if we're exposed. I've had healthcare workers ask me, should I get tested every day? Well, there's really no value in that. And you could also test negative in the morning and positive the same day in the afternoon. So it's really something that we want to be judicious about how we test and when we do. And then if we do have symptoms, this isolation criteria is available through WHO and CDC, specifically to look at what type of isolation based on the risk of exposure and for how long. So for example, if you have a healthcare worker, let's say you're going in to place a PICC line and the patient has a mask and you have a mask, and you don't know that that patient is COVID positive and they haven't been diagnosed yet, and you're exposed and you find out the next day that they're COVID positive. Because both of you had a mask on, that greatly reduces the risk of contamination. And so that would be a low risk activity versus if neither of you had a mask on, or if you did and the patient didn't, that certainly ups the ante, if you will, and increases the risk. And so isolation discontinuation is something that's really important because we're finding viral particles in patients for much longer than 14 days after the initial diagnosis. And so this varies by patient. And so it's very likely that you could have patients that still test positive for well beyond that 14-day incubation time period. And as we conclude here, the new normal is going to be an evolving thing. It's something that will have probably some elements of social distancing, which can cause, again, a whole host of other issues with isolationism. We recognize that there's going to be additional waves, most likely, across the world, depending upon how the public health efforts are going. But the good news is that UV light kills it in the environment, which is good, but it doesn't kill it in people. So there's really this misconception about just because it gets hotter that the virus is just going to wipe away, and that's certainly not the case. We'll want to continue to look at global disease surveillance to understand what the true burden of illness is, and then share that data. And I think right now there's a lot of great things that are happening with data sharing, multidisciplinary collaboration across the globe. And this gives me a lot of hope for how we can combat this, because this virus is not going to go anywhere. It's not going to, just be eradicated from the world. So we need to figure out a way to sort of coexist with it. And part of that's going to be with good clinical practices related to infection prevention and control, hospital preparedness, and also anticipating for how can we meet supply chain shortages. So as we conclude, I think this WoCoVA conference is very timely, because it's an opportunity for us to come together and say, how do we sort of craft what that new normal is? What's realistic? What's not? How do we hardwire basic infection control practices in the world of vascular access so that we can stop that transmission completely dead? We also want to look at vulnerable populations and notice that that is not just for the patient, but that's also for us. So if we have a vascular access specialist that's over 65 or has a lot of chronic comorbidities and health conditions, then that's a risk that we need to be very prepared to address and potentially mitigate them out of that frontline clinical role. But most of what we're talking about today can be easily prevented through good infection control practices like washing our hands, wearing personal protective equipment, self-isolation if we're ill, cleaning the clinical environment of care. And again, we cannot forget how important it is for us to stay healthy mentally, physically, and emotionally. Thanks very much for this opportunity to present to this WoCoVA virtual conference, and hope you enjoy the rest of the sessions.
Thank you very much, Hudson. Josie, please, maybe you have some remarks on this presentation. Oh.
Josie, before you continue, please unmute your microphone.
Josie, you're muted.
Yeah, bottom left corner.
Yes, try again.
I think
Yes.
Hudson provides for us an excellent overview of the responsibilities, not only for us as citizens, but as patients in the hospital and the caretakers in the hospital. I felt that was very, very informational. And I have to say that Hudson has been an excellent resource for us practitioners, vascular access practitioners, through this whole COVID-19 episode to provide us with ongoing information through webinars and education and publication. So excellent.
Thank you very much, Josie. And Hudson will also be on the panel later on after the break we have when we had all the presentations presented for you. So if you have any questions, and we do get a lot of questions coming in at the moment, but we will handle the questions later on directly to our live presenters. From here, I want to go to a message from 3M. He's one of our sponsors, and I think it's good to have input from our sponsors as well.
As a scientist at 3M, I've dedicated my life to improving healthcare. My father taught me that to find a solution, you have to fully understand the problem. You have to understand people, not only patients, but also doctors and nurses. My team developed a solution that helps reduce the risk of infections during hospital stays. That's how you protect patients and achieve better outcomes. There's more to do, but together, we're working to improve lives.